Hello, my name is Lucia de Franceschi. I'm professor of medicine at University of Verona with an annual appointment at the Children's Hospital, Harvard Medical School, Boston. And today we will discussing the importance of recognizing the burden of disease in sickle cell disease for patients and caregivers. Sickle cell disease is a monogenic disorder supported by or caused by the presence of a mutation on the hemoglobin responsible for the synthesis of pathological hemoglobin S. And then genotypes involved in sickle cell disease are either homozygous SS or the double heterozygosity S plus C or plus beta tal 0 or beta tal plus. Altogether, all these genotypes are under the umbrella of sickle cell disease. And the key point is the peculiar biochemical characteristic of hemoglobin S, which polymerize under the oxygenation, responsible for the damage of red cells, resulting in the early removal of red cells by the peripheral circulation by either erythrophagocytosis for 2/3 and for 1/3 as intravascular hemolysis. The intravascular hemolysis is responsible for reduce NO bioavailability, increase intravascular oxidative stress, and the direct interface between plasma and red cells is the vascular endothelium. And the increased oxidative stress, the direct effect, negative effect of free hemoglobin and free heme results in endothelial dysfunction with the activation of the coagulation pathway, activation of the alternative complement pathway, and the involvement of an amplified inflammatory response in which results in an entrapment of sickle red cells and neutrophils into the microcirculation. And the microcirculation of peculiar organ. And the peculiarity of this organ is absolutely related to their functional anatomy, which is characterized by slacking circulation, high extraction of oxygen, and a low pH. This results in as I mentioned, an entrapment of red cells and neutrophils, reduction in the blood flow, and ischemic and reperfusion stress that can be then transformed in a damage, which the main clinical manifestation is represented by pain. This is responsible for both acute and chronic sickle cell related clinical manifestation, which are mainly involving bone and kidney, lung and brain, liver and heart, responsible for acute manifestations such as vaso-occlusive crisis or chronic manifestation such as pulmonary hypertension or cardiovascular disease or cerebrovascular disease, as well as increased susceptibility to infection and septicemia. As I mentioned before, sickle cell disease is a genetic disorder. So we have a patient journey with patient presenting complications since they are a child to our adolescents, young adults, and adults. And of course, due to the fact that acute complications are recurrent and severe, of course, and then we have changes in the life, for example, the transition between adolescence to young adult, all these factors have a synergic action on the clinical manifestation of sickle cell disease. For example, in children, the main clinical manifestation is represented by acute vaso-occlusive crisis, and peculiar of children is, for example, dactylitis, which is the involvement of bone in bone vaso-occlusive crisis with edema of the hands, and is extremely painful for this young patient. together with the acute chest syndrome, which is the involvement of the lungs in severe forms with possible severe difficulties in gas exchanges. But the pediatric population is mainly characterized by fever and infections, and this can be a life-threatening condition with patients that still can die for these causes even in high-income countries. That's why antibiotic prophylaxis and vaccination strategy definitely change the survival rate of this patient. In adults, we still see acute and chronic pain manifestation as well as vaso-occlusive crisis, and acute chest syndrome is still representing a life-threatening condition also for adult patients. In adult patient, what is young adult, and especially what we see in elderly patients with sickle cell disease in high incoming country, is that sickle cell related cardiomyopathy and kidney disease represent the main cause of death, of early death for these patients. And of course, when we consider the quality of life, the presence of pulmonary hypertension as well as vascular necrosis is responsible for definitely a worsened effect on patient quality of life, requiring an increased access to the healthcare system, and of course a comprehensive sickle cell center to be in charge for these complex patients. The complexity, the biocomplexity of sickle cell disease, as well as the organ damage, the chronic organ damage. There is a cumulative effect of the different acute vaso-occlusive crises. This definitely negatively impact patients on both physical well-being, but also on psychological and social state. And indeed, the poor physical well-being result in reduced engagement of patients, for example, in recreational activities, but also in social interaction, in social support, with a final negative effect on reduced satisfaction with life of patients with sickle cell disease. And this is even worsened by the fact that there are identified barriers to the care of patients with sickle cell disease that are related, for example, to the access of the patient at the emergency department, where not all the emergency department are aware about how to treat sickle cell disease acute events. So the pain treatment may be delayed, and the experience of pain and vaso-occlusive crisis may be devastating in both children and adults with sickle cell disease. In addition, as I mentioned before, there is a key moment in patient life, which is, for example, the transition from pediatric care to adult care. So there may be barriers related to the accessibility of the adult centers for sickle cell disease, or the absence of these adult centers for sickle cell disease in some area, even in the high-income countries, or the absence or the fact that patients are not aware that there are specialized centers for sickle cell disease available. Finally, we don't have to forget that this sickle cell disease is also an ethnical related disorder, and the discrimination factors are still there, even in for patients with sickle cell disease, even in high-income countries. In the setting of sickle cell disease, because we are talking about patients that are children, adolescents, and young adult, and the fact that part of these patients are also in areas where the awareness on the disease is not so well disseminated. So that's why it's important any action we can we can build up to increase education, also physician, about sickle cell disease. And indeed, the fact that acute vaso-occlusive crises are unpredictable. So it can happen. They can happen where the patient live, but also if patient is on vacation. And sometimes patient arrives at the emergency department with already some severe complication and need to be early treated and intensively treated within 30 minutes based on the different guidelines in Europe and the United States whenever they arrive to emergency department. Another important factor related to the accessibility of the patient for the patient to the service is also related to the fact that patient with sickle cell disease may not be able to reach centers that they know that knows how to deal with the sickle cell disease. This is mainly related to management of chronic sickle cell related complication. So one possibility which need still to be built up is a connection between emergency department and sickle cell comprehensive center in order to maintain a fil rouge, so a connection between emergency department and clinics. Another point that is very important is that sometimes in some context, socioeconomical disadvantages can contribute to increase the barriers in the quality of care of this patient. Hello, my name is Lucia de Franceschi. I'm professor of medicine at University of Verona with an annual appointment at the Children's Hospital, Harvard Medical School, Boston. With the possibility to use hematopoietic stem cell transplantation is very important, considering that there are several limitations. One is represented by the age, so reduce adverse event, severe adverse event whenever the bone marrow transplantation is carried out in patients younger than 12 years of age. And of course, the availability of matched sibling donor, which are limited in population with sickle cell disease compared, for example, to a patient with beta thalassemia, which is another severe hemoglobinopathy. Considering the tools, the therapeutic tools that are available for a patient with sickle cell disease, hydroxyurea represent still now the gold standard treatment for both children and adults with sickle cell disease, and the powerful action of hydroxyurea is the multimodal function of hydroxyurea, targeting the synthesis of hemoglobin, of fetal hemoglobin, modulating inflammatory vasculopathy by both promoting NO production and modulating neutrophil activation, and also contributing to the reduction in the severe clinical manifestation of sickle cell disease, both in adult and in children. Considering blood transfusion as a strategy, the goal is to stably reduce level hemoglobin S and of the sickle red cell in the peripheral circulation. It can be used either as acute or a chronic approach with different strategy. One is the simple transfusion. The second one is a manual or automatized exchange. Concerning L-glutamine, which availability is limited to the United States, its mechanism of action is related to antioxidant system inside the red cells, so increasing the antioxidant properties of red cells. And there is a couple of studies showing the reduction of vaso-occlusive crises, but the lacking in the knowledge of the mechanism of action and also on the long-term effect of treatment with this molecule. There is some caution within the scientific community in the use of this molecule in children, adolescents, or young adults with sickle cell disease. So concerning the novel therapy for sickle cell disease, we really have a limited portfolio due to the fact that, for example, for crizanlizumab, which is a biological molecule, so an antibody direct against selectin, which is a proadhesion molecule expressed on the endothelial, the surface of endothelial cells, vascular endothelial cells. The study in phase 3 have demonstrated fail in demonstrating the protective effect of crizanlizumab against vaso-occlusive crisis in adult patients with sickle cell disease. This makes EMA, so the European Medical Agency, to revoke the approval for the use of crizanlizumab. On the other side, the second group of molecules, which were represented by pure anti-cycling agents such as voxelotor and the second generation osivelotor, these were stopped due to the fact that were recognized an increase that the risk of death in post-marketing studies that were conducted in sub-Saharan area. So right now, we have really solid data only on curative treatment. That means cell therapies, which is represented by either gene editing strategy or by a gene therapy strategy with lentivirus. So in the case of gene editing, the strategy is to use a CRISPR-Cas gene editing approach targeting BCL11, increasing fetal hemoglobin expression and reducing the amount of hemoglobin S synthesis with an incredible positive impact on the vaso-occlusive crisis rate. On the other side, the gene therapy based on lentivirus, which means to introduce the synthesis of a new hemoglobin, which reduce on the other side in the total balance synthesis of the hemoglobin, the pathological hemoglobin S has similar results of the gene editing, less brilliant. And on the other side, there were some questioning by the scientific community related to the increased acute oncohematological events that were described in a group of patients treated with the lentivirus treatment, even if the company were able to demonstrate not a direct linking between the treatment and this acute event that was myelodysplastic and acute leukemia. Up to now, the progress in the knowledge on sickle cell disease allowed to identify and to confirm new targets. One is represented by the red cell metabolism, and in particular, the possibility to modulate the activity of pyruvate kinase, which is a key enzyme in the terminal phase of the glycolytic pathway, which is important in supporting the energy for red cells, but also in well-functioning of antioxidant system. And we have to think that red cells are extremely dependent by glycolytic system and by the antioxidant system due to the fact that they survive for a long time into the peripheral circulation. Up to now, we have two molecules that are available, so pyruvate kinase activator. One is mitapivat, which is an activator of both pyruvate kinase R and pyruvate kinase M, and the other one is etavopivat, which is an activator only of pyruvate kinase R. The PK activators really represent a unique opportunity for patients with sickle cell disease, and the results from the studies that are available and were presented at the ASH meeting are suggesting that a PK activator, in particular mitapivat, is able to improve hemolysis in patients with sickle cell disease, so increase the hemoglobin, reduce markers of hemolysis, and there was also a positive impact on the rate of vaso-occlusive crisis in patients treated with mitapivat. These data are very important because patients that were treated with mitapivat were either on hydroxyurea, so thinking to the strategy of combination treatment, but also naive. So that's is helping in understanding how the extension of the therapeutic portfolio may be extremely important in in clinical management of patients with sickle cell disease. On the other side, there are a new fetal hemoglobin inducer. Among this group, there is a very interesting molecule, which is the N-decitabine, linked to a molecule which is increasing the survival, the half-life of this molecule into the peripheral circulation, which has been shown to increase fetal hemoglobin in both mouse model for sickle cell disease and in a proof of concept study. On the other side, we have also other strategies targeting vascular endothelial dysfunction represented by epeleuton, which is a high bioavailable fatty acid, omega-3 fatty acid, which may contribute to reduce endothelial dysfunction in sickle cell disease, together with improvement in red cell features. Up to now, there were still some studies on other molecule directed to inflammatory vasculopathy, such as inclacumab, but recently communicated the failure of reaching the outcomes in phase 3 study in patients with sickle cell disease, suggesting that we need multimodal treatment or combination of different treatments with different targets to control clinical manifestation of sickle cell disease. As I mentioned before, sickle cell disease is a chronic disorder, deeply touching life of patients from pediatric age to adult age. And of course, the viability of new possible therapies is important, because what we would like to offer to patient is a personalized treatment, which can be looked in a dynamic way, so during the life of the patient, but also can be specific of a particular period of patient life. Let's think to women that want to have a baby, so to get pregnant, or for example, adolescents with a severe clinical manifestation. This means, on the other side, to build up around the patient a multidisciplinary team which can be involved in transition of the patient from pediatric to adult care, but also in working with the patient throughout his or her disease. And in this case, patient education, as well as family education, and also the fact that the involvement of the patient in their own treatment is very important, together with the possibility to ensure the equity of the access to the healthcare system and the dissemination of the knowledge of this disease throughout physician. I'm thinking, for example, to the emergency department physician, who are key medical doctor in patient's life. Hello, my name is Lucia de Franceschi. I'm professor of medicine at University of Verona, with an annual appointment at the Children's Hospital, Harvard Medical School, Boston. This question is important in what we can do for patient and how we can improve care for this patient. If we look to the natural history of the disease, sickle cell has an high mortality and morbidity, which definitely in the high-incoming countries has improved in the last 2 decades. And this means that today we have young adult, but also elderly patient reaching ages that were not absolutely present when we look at the survival curves 20 years ago. And the improvement in life expectancy is related to the fact that were introduced the newborn screening with the early diagnosis of sickle cell disease. There was also established a screening program for cerebrovascular disease, but also vaccinational programs, antibiotic prophylaxis and penicillin prophylaxis in pediatric population. And these definitely have improve life expectancy of pediatric population. On the other side, when we reach the adults, what we have observed was that the risk of death was still there compared to healthy population, but there was an improvement in survival rate of between 20 to 25 years in the high incoming countries. That means that we have a new population of patients or with sickle cell disease that present a very complex disease characterized by chronic organ damage, and this means that patient needs to have easy access to comprehensive sickle cell centers where we have a multidisciplinary teams that knows the disease, know the complication, know how to offer the best therapy to treat the complication and to deal with the complex disease. On the other side, we have some um, differences when we look at patients with sickle cell disease, even in the high-incoming country, when we compare the accessibility to the healthcare system. In Europe, there is a public health care system with some difference within countries, but generally there is a public access to the healthcare systems, whereas in the United States, the accessibility to the healthcare system has some restriction, and there are some critical point, especially when we have patients moving from the pediatric care to the adult care. And of course, the transition right now represented one of the key questions, and still with the enormous needs in order to protect the patient against the fact that the lacking of continuous monitoring may result in more severe organ complication. So, as we mentioned, the presence of comprehensive sickle cell center, which needs to build up a multidisciplinary team, is important. Is more than important. Is crucial for both survival of the patient, quality of the life of the patient, and the fact that the presence of a professionist that knows about sickle cell disease are more able to find rapidly the right answer for unsolved question or key question from the patient. So the teams, the multidisciplinary teams can be identified into main interacting group of healthcare professionals. One is the core team, which is represented by pediatric hematology, adult hematology, internal medicine doctor, and then of course they should closely talk with the doctor, the family doctor, or the primary care physician or pediatrician when the patient are there at home. And of course, the involvement of the emergency department, the involvement also of the social workers related to the deep impact of this disease on life of patient with sickle cell disease, and of course the presence of psychological support of psychiatrists, because depression, which is been described, especially in adult patient with sickle cell disease, is it can worst clinical manifestation, clinical manifestation related to sickle cell disease. Within this team, we need to have blood bank and transfusion service open for discussion of complex cases, both in clinical management of acute events, but also of chronic events. The extended team, that means the ultra specialists that need to be aware about sickle cell disease and need to be involved in treatment of patients with sickle cell disease, are going from neurologists, nephrologists, cardiologists, ophthalmologists, radiologists, and of course in special condition, gynecologists and obstetrician, and of course a transition coordinator, because as I mentioned before, transition from pediatric to adult care is still a key point where we need all to work on. Yeah, so the transition from pediatric care to adult service is really a key moment, both for patient and for physician, but especially for patient, because it is correspond to a moment in which each patient is taking his own life and bringing, independently from the parents, his own or her own responsibility towards their daily life. So that is important because, for example, in my clinic, we closely work with pediatrician. We have generated materials, some brochure and some podcasts for patient in transition for the pediatric clinic to the adult clinic. And we have a case manager or a transition manager who is in consultation with us and with the pediatrician during the 2 years that we decide as a key years for the transition from the pediatric to the adult clinic, which means from 16 to 18. So what we learn from our experience is that each center has to start very early planning the transition of pediatric patient to adult care. It's crucial to identify people that are part of the adult team, that are present in co-consultation with the pediatrician, and we use a transition coordinator. In our case, was a case manager in maintaining the continuity between pediatric care and adult care. And of course, this always need to have the presence of a psychosocial support that can be a psychologist, but in our case was a counselor, just to identify an empowering patient identity in order to promote the growth and health growth, psychological growth. The patients becoming more and more conscious about his or her own disease and how to deal and to also talk with the adult care physician. This is again an important question because when we think how to implement and coordinate our two different actions, which are extremely important. One is to identify, for example, emergency department as a critical point of access of the patient during acute events. So we have to work with emergency department in order to maintain an awareness on sickle cell disease, and whenever it's possible to identify common clinical pathway in order to make the patient to go throughout the experience of acute vaso-occlusive crisis in a good way, is if possible a good way. A second point is that the center, the Comprehensive Sickle Cell Center or Center of Excellence, have the responsibility of disseminating the knowledge on sickle cell disease and to improve a program from transition of sickle cell patient from pediatric to adult care, and of course to maintain vivid the presence of a multidisciplinary engaged team on sickle cell disease. This should also be built up in a close crosstalk with the family, ensuring the family engagement and the involvement of healthcare's system in supporting this patient throughout their patient journey, but also in trying to push the healthcare system to address the still unmet need that are present for this patient. There are also new tools that we can use in both dissemination but also in consultation on second opinion on complex patient, especially for centers that are not center of experience, and this can be done by telemedicine, but also by offering an easy accessibility to both patient and physician to discuss complex cases and to contribute to the generation of updated guidelines at national and European or international level.